Hello, Monica. So, welcome everybody for the session. Hello, Pooja. Hi, Jay. Hi, Zalpa. Hi, Raman. Hi, hi, everybody. So, welcome to the session. As you know, we are meeting today to discuss the very, very important ADC concept, which is pregnancy and oral health. And hi, Garima. Hello, Pavneet. Hello, Bharti. Hi, Pavneet. So, Facebook is also working fine. All right. So, as you all know that we are meeting today to discuss extremely crucial concept. If you've enrolled with us and you're doing the program, then you have already done few aspects of this topic with the CV classes and with the special topic classes. And there is hot notes which have been created for the same, but I wanted to cover in depth as there are more recent guidelines released by a lot of Australian services, health services for pregnancy and management of oral health care during pregnancy. So to see that why the latest guidelines are still getting released, it gives you an overview and the factual understanding of the point that pregnancy and related SBQs are extremely important for the examination. And as I was going through the past year papers, I realized when I was looking for certain pregnancy oriented SBQs specifically, I found that per exam, at least 3, 4 pregnancy related SBQs get asked. So all the public sessions that we do, we make sure that we cover the concepts which are giving you at least per exam 3 to 4 SBQs with one concept, with one lecture only. So if you have, say, total about 56 SBQs, and every week we are doing concepts which cover at least 3, 4 SBQs. So for sure 10 to 15 public sessions will give you that overview, which will at least help you to target not just one but at least multiple SBQs in the exam. So that's my real motive to conduct these sessions, because we are doing questions anyways in our internal classes. The ultimate advanced file we are doing, the UF volume 1, you already have classes for. Mega master classes you have. So there is quite stress on the SBQ classes that we are already doing. We're learning the rash technique, applying them. But then you need, as you also know, that rash technique cannot be applied without very strong conceptual base. So ADC exam, if you focus just by doing questions or just by doing only few guidelines that you know, that please know that that will cover only the foundation 60% of your preparation. Doing the past papers and doing the basic guidelines like TG, ODEL, and important other guidelines like trauma guidelines, infection control guidelines. So they only cover the 60% of the exam, the rest 40%, and where the success lies, that is where the success lies. Success lies above 75%, right? So 60 to 75 is the borderline. It's easier to cross. And below 60%, yes, there has to be imminent effort, which will, catapult you into the 75% above, percentile. So that preparation where you score 80%, 85% in exam and safely get through, even with the lower cutoffs, that happens with very strong foundational conceptual base. So all the hot topics that you have in that, I think if I cover all the 10 subjects that I have given you the hot notes for, and if I include all the hot topics per subject, then you have above 110 or 120 hot notes and hot topics. If all those topics, if you are doing in depth, learning them in depth, revising them as the program advises you to that number of times, you will see that an exam with the question practice during the classes, during the assessment and the mock practice, during the weekly plans and the preparation time that you get on the LMS, on the Winspurt app, all your daily mocks that you're doing, everything when you practice, and the classes also that you take for the questions, and reading the hot notes in depth, and then doing these public sessions. Other than that, your CV classes, special topics, and important article classes throughout the program. Then you get a wholesome preparation for the examination, and safely you can make it to 85%. That would not be an effort, or that would not feel like a burden. Does that make sense? Of course, the effort is in preparing all these subjects and preparing all these arenas, including your notes, including your classes, including your daily mocks, and watching all the CV, special topics, and conceptual classes. Of course, the effort goes in here, but it is so well defined, and it is guided for you every day, what you have to read, what you have to watch, what mock you have to take every single day. So practically every single day you're doing the mocks, you're reading the notes, and you're watching the sessions. Cumulatively, you're also asking me doubts on a single every single day. So again, reiterating on these fact that if you continue to do these four approaches every single day, then the 85% plus score in the exam, that becomes effortless. So see, effortless things are not built overnight, right? Some things that look effortless actually require a lot of effort going on behind. Do you all agree with that? And anything in the life you see, which seems extremely effortless, requires a lot of effort behind the scenes. So your effortless pass and your effortless A's and grades, passing grades in the exam, will require these 5 months of the preparation and effort that you have put in. And that effort will not come in bursts. That effort cannot be cyclic. That effort cannot be random. That effort has to be dedicatedly decided, planned, and prepared from the first day on till the examination day, even during the exam days. Agreed? So the effort has to be decided, defined, and planned for you. So Winspurt provides you that plan also. So you don't have to put the effort on designing the plan. So the plan is designed for you. Now your job is to put the effort every single day, show up for each class, watch each class, revise as it's needed, take mocks every single day, get your scores on the highest and the highest percentile. And are you even in any confusion when you get your scores? You get the ranking feature now, right? So everybody gets to see their ranks. Every mock that you're taking with your cohort is giving you the real time experience of how these people are going to take the exam with you and where you stand. So you're not even in the darkness, you're not even in shades that, okay, if thousand of people are going for the examination, those thousand people are already taking the mocks with you. So your rankings and everything is also giving you the benchmark, what is the bar where you stand. So that even if you want to make improvements by radical methods or by slow, gradual, incremental methods, no matter how it helps, but there is still probability and possibility to even see where you stand today with your existing cohort. So no other program is going to give you that level of in-depth, you know, complete transparency where you stand with your cohort. So use that feature and improve with whatever your methods may be, incremental or radical, but get in the hard work, get in the effort, and then make your success effortless. So every single class that we are taking every Tuesday, and then internal classes, applying rash techniques, and rash is getting fueled with your hot notes, with your power notes, and with your CV special, important, and these public sessions. So keep feeding your rash technique with all these concepts so that in exam it becomes an effortless attempt, and passing grades are also served to you in an effortless way. That's the 100% intention and motive. Every day, every single class, we set this intention, and on the examination, we'll achieve that success. So I hope everyone's ready to start with pregnancy and oral health discussion. Latest guidelines have been added. I've been adding them to the hot notes. So all your hot notes on pregnancy and oral health in the health promotion subject, are updated with the most recent guidelines, and I'm just feeding them all the new guidelines, all the new articles that I receive and get. I'm just putting them in the hot notes, so they are extremely updated. Today I'm going to use all those guidelines and bring the important points which are directly examination questions. After discussion of this concept, we'll apply also to the SBQs, how it actually comes in the exam. I'll take a real examination example and we'll solve that SBQ. All right, so I hope everyone's ready and excited to learn this very, very crucial concept. So yes, so we are going to be talking about pregnancy and oral health. And first, we are going to be talking about what are the most important changes in pregnancy that is commonly found as a dentist when pregnant patients they come for a dental checkup, and what are the oral manifestations, what are the common changes that happen in their body and again in their oral cavity, how you would identify, what are the reasons behind it. So number one thing is that in pregnancy, there is definitely a surge of hormones, right? So there is and fluctuations as well. So most importantly, it's the estrogen and progesterone having complete hormonal fluctuations throughout the trimesters, which gives radical physiological changes in a pregnant woman's body. And then there are dietary changes also. There are particularly increased cravings for certain foods also. Then even there are tendencies to frequently snack between the meals. So that is why to maintain good oral health in pregnant women is extremely important, and that's where your role comes in. So investigation and information gathering cluster questions are extremely important in pregnancy because you need to know what are the oral findings, how you will investigate them. So what are the various diseases which you would find in pregnant women's oral cavity? So that is why you will look for the signs and the investigations would be selected. So information gathering cluster should be strong. And then the professionalism and health promotion, because you will now learn that there is link between a lot of oral conditions with severe or unfavorable pregnancy outcomes. So health promotion becomes extremely crucial in pregnant women because there are actually adverse outcomes in pregnant women related to the birth of the child, which could have been prevented or which could be prevented if the oral health is promoted in the pregnant women. So basically, because of the hormonal impact, there is predominantly, and then the changing diet and everything, and the nausea and the morning sickness, there are immediate dental and oral impact. So gingivitis and periodontitis is specially affected. Caries, absolutely, it's not a direct effect of pregnancy, but it is still increased risk because of the changes of dietary patterns. There is frequent snacking associated, right? The behavior are changes. Maybe the pregnant women also to suppress their nausea. Maybe they want more carbonated drinks as well. So they also contain sugar. So caries risk is definitely increased. Erosion risk is definitely increased by their behavior changes, frequent snacking, sugary cravings, acidic carbonated drink consumption. This all leads to increased caries risk. That's the number one effect. Then there is a gingivitis effect. So because of accumulation of hormones in the body, there is definitely changes in the gingival vasculature. So the vascularity of the gingiva changes, the reaction and immune response to the existing plaque also changes. So there is also changes in the neutrophil and phagocytosis effects, right? And the plaque can lead to, so all this accumulated plaque and exaggerated response to the plaque can lead to gingivitis, right? And after 8th month, usually then it starts to subside when the hormones also decline. So there is increased bleeding on probing, For gingivitis, what is your investigations that will show you what are the positive signs that you will see? There will be increased bleeding on probing. There would be associated swelling and redness in your gingiva. So gingivitis is a very common finding associated in your pregnant patient. Periodontitis, again, pregnancy on its own will not cause or lead to periodontitis because it is again a multifactorial disease. It's not something that is just caused by pregnancy or just diabetes will come and lead to, pregnancy, periodontitis. It is definitely a multifactorial, situation which goes on in the patient. So again, because of the changes in the immunological responses, even periodontitis is an increased risk in pregnant women. And now in today's session, I'm going to be talking about a very new guideline and a very new concept which has not been covered in either of your hot notes or anywhere. So I want to talk about very important concept and I'm sure you all would be excited. Smoking and periodontitis. Now tell me, everyone is excited to learn about because now I'm seeing there are certain questions where we are already having questions where pregnant women have high carbonated drinks addictions, right? Sugary cravings. Now there will be a trend and smoking is also extremely hot in exam. So as newer and newer questions come and the new guidelines are getting released, there is also a trend that certain pregnant women are also smoking. So there is definitely an increased risk of periodontal disease with smoking, right? Then with diabetes also. So pregnancy is linked sometimes with gestational diabetes as well. So pregnancy, periodontitis, smoking, and gestational diabetes, that becomes again a multifactorial situation which can impact the health of the unborn child and can lead to adverse effects on the overall health of the child and also affect the birth. So now in today's class, what is extremely new that you will learn will be managing of smoking and pregnancy. I'm going to give you very strict Australian guidelines, the recommendations and rules, because the direct questions when they get asked, so there will be some factual concepts. When we talk about smoking and pregnancy, there are certain factual concepts, there are certain sequencing concepts, there are certain also as the history changes how it will apply. So it is a direct rash feeder. Agreed, everybody? So that guideline that I'm going to talk about, smoking and pregnancy, has a specific guidelines. So it's a direct rash feeder. So I'm sure everybody is excited to learn about that as well. So in pregnancy, the progression of periodontal disease, existing periodontal disease, is seen that it may progress. So pregnancy, because of its excessive hormones, can lead to rapid progression of periodontal disease. So the probing depths you will find are deeper, right? And that is why encouragement of oral hygiene practices and health promotion will come extremely handy to handle the pregnant patients who have periodontal disease. Another common oral manifestation which you may find is pyogenic granuloma. Pyogenic granulomas we have covered in depth entirely in our Odell cases, right? The Odell case, we have covered it. What are the pregnancy-related pyogenic granuloma? And in the non-pregnant patients also, what are the specific different etiologies, the histology, pathophysiology, and the management. All the aspects we have covered for the pyogenic granuloma. So we must know that it affects almost close to 5% of women, which is actually high prevalence. And that is why you must investigate for pyogenic granuloma. They tend to bleed easily also. They are highly vascular and they can become painful. They can get supra-infected and ulcerated, right? So usually the management during the pregnancy for pyogenic granuloma is that you will educate the patient for extra oral hygiene measures. You will provide them scaling and educate them for meticulous oral hygiene at home. And usually the excision and the surgical component is left after the birth of the child, right? So you should avoid excision Unless it becomes supra-infected and there's a risk of spread of infection, then of course in emergency situations the surgical excision may be conducted, but there should be no medical contraindication for any surgery, right? So you must also tell that there is a high risk of recurrence. That is why excision is avoided, and mostly the meticulous oral hygiene helps you in reducing the size of it and managing it while the patient's pregnant. So the stand on pyogenic granuloma is clear for everybody. Now the other oral manifestation would be erosion. So again, we know the morning sickness, the nausea, the vomiting, and it's repeatedly. Again, I tell you, when I'm covering every slide in today's session, every slide is a question which is actually being asked in exam, or there will be some slides which are going to give you concepts which are going to be asked in exam, will be so new, but you will be 100% ready for them. So erosion risk is extremely higher, again because of the intrinsic erosion, because of the acidic exposure, persistent vomiting, and then again for the extrinsic erosion because of excessive carbonated drink consumption. The number one advice which should be given is that immediate brushing should be totally avoided. If there is an acidic episode because of vomiting, your immediate toothbrushing should absolutely be avoided. Is that right? Because at that period, your enamel is highly demineralized state, in acidic state, and if you brush immediately after vomiting exposure, there would be more tooth loss. So at least minimum 30 minutes of wait time is advised before they can. And that is why immediately after getting a vomiting episode, there has to be rinsing. Now, the rinsing can be with three agents. Rinsing can be with three agents, and there are multiple Australian guidelines, and every guideline has recommended one or the other. Okay, so one is the water, rinsing immediately with water. Certain guidelines also recommend milk because of the calcium, and it helps in strengthening the enamel at that point. But milk is not so commonly in all the guidelines. What is mostly widely present in all the guidelines are, first, number one, water, sodium bicarbonate, absolutely correct, Susan, Kinza, Darsana, sodium bicarbonate, and the third agent is 220 ppm fluoride mouthwash. These are three options, and ADC loves to throw all the three in the same question as a multiple choice question. Now you apply rash, right? When you have all the correct options, we are not worried, right? Are we worried? Because we will apply rash and we will get through it even when the multiple options are present, which are correct. So I'm going to give you the final verdict on the sequencing as well. But these are the 5 important, or you can say, yeah, 6 important oral findings. Right? So everybody's understood all the conditions and diseases that you will find in oral cavity, possibility, and their management, and how you can prevent them. Now there are certain pregnancy effects, how the oral health will have on the general health. One thing is you've understood how pregnancy will give you oral effects. Now let's talk about how those oral conditions will affect the general health of the patient as well as the neonatal health. So the health of the unborn child. Number one effect is the preterm birth. Pregnant women who have severe periodontal disease may have an increased risk for having a low birth weight or a preterm child. So preterm would be any baby born between the 37 weeks. At 37 weeks, the term gets completed, and any birth after 37 weeks would be called complete full term, right? So the preterm birth would be anything before week 37, and pregnant women who have severe periodontal disease are at higher risk of low birth weight and a preterm birth. Because there has been a finding that periodontal disease or periodontitis, gingivitis or periodontitis, it leads to some presence of inflammatory markers in the bloodstream which have shown to have an impact on triggering and onsetting an early labor. Is that clear for everyone? Also, that leads to your preeclampsia. So those inflammatory markers in excessive periodontal, severe periodontal disease present in pregnant women also leads to preeclampsia, which is the hypertension and proteinuria. Preeclampsia includes hypertension plus proteinuria. So again, the inflammatory markers again are linked with that. So it was found absolutely scientifically that there is a higher risk of preeclampsia if there is a severe periodontal disease which is present, right? And again, the concept, underlying concept is what? The inflammation and the inflammatory markers, and it goes and directly affects the placenta and leads to the hypertension and triggers the early labor onset as well as the hypertension. Now, also there's a link between the periodontal disease and gestational diabetes. It has been found when there is severe periodontal disease in pregnant patient, there is a greater risk of getting gestational diabetes. Now, for the health of the neonatal or the unborn child, again, there is a direct impact on the unborn child's health as well. There is adverse pregnancy outcomes. There is low birth weight. So there would be a risk factor of low birth weight and may have an impact on the neonatal health. So these are your effects of oral health and oral diseases on the general health of pregnant women. Right? Clear for everyone? Now, let's talk about how can you prevent these oral diseases. So when you prevent the oral diseases, control the oral disease, you ultimately improve the pregnant woman's general health and the unborn child's general health. Yes or no, please? So you see where your role comes in, right? And you see how this is an extremely important examination topic. So now let's talk about the prevention. So prevention will make sure that you will educate the patient about meticulous oral hygiene practices, plaque control, maintaining fluoride intake, whether through your water or your toothpaste or your mouthwashes, or also reducing the caries risk by intervening and educating the patient about reducing the amount of sugary drinks, right? And then the third one is emphasizing on plaque control and quitting the smoking. Now, quitting smoking is a repeated pattern being covered in many guidelines. Every single guideline that I read, I prepared, emphasized on educating the patient on quitting smoking. And there have been so many questions in the pregnant women SBQs in the exam right now, which are talking about fluoride, which are talking about caries control, which are talking about periodontal disease control, plaque control, even talking about localized infections. So there has been in 2020 the newer treatment guidelines and the newer guidelines on use of NSAIDs, right? They have been released in the year 2020. So TG 2019 version also doesn't have the updated stance on the NSAID use in pregnancy. But the ETG, which was released thereafter, has the updated guidelines on the use of NSAIDs. And in today's class, I'm going to give you that newer concept on the NSAIDs as well, right? So we are going to, so the localized infection, the extraction, the periodontal disease, everything ADC is already asking. Is that right? Majority of the concepts, 90% are already getting asked. The new 10% that we also do, again, at Winspert, we will go above and beyond the syllabus with every concept. So there will be now questions about specific smoking quitting guidelines. Now they are very different from your normal patients. So again, you have done your quitting smoking concepts and flowcharts and guidelines with me, right? In the internal classes, we have done that. In our health promotion hot notes, we have prepared that. There is a specific protocol that we are following, and you all are now fully aware of the exclusive guidelines and health promotion protocol for quitting the smoking. And there is a lot of sequencing. It's not random. You cannot choose those options randomly. There is a process. There is a scientific evidential method to choose those answers as well. So every question that you learn to prepare at Winspert would be guided by evidences and scientific evidences to apply the rash. Now, there have not yet been some questions on how to educate the pregnant patient on quitting smoking, and you cannot apply exactly those guidelines to the pregnant patient. There are certain, of course, nuances and certain differences which we are going to be talking about today. So prevention of oral disease is the most important. Plaque control, meticulous oral hygiene, and it helps you in reducing the gingivitis and other periodontal disease like periodontitis, pyogenic granuloma. Everything can be prevented. And smoking cessation advice should be the part of preventive strategy in pregnant women because, again, smoking has a direct effect on placenta, on the health of the unborn child, as well as it has effect on the periodontitis. So all this will help preventing oral disease and ultimately improve the general health of the pregnant woman and the child. Now, what are the stances on the dental treatment in pregnancy? What are the guidelines on radiography? What are the guidelines on, using the local anesthesia? These are also covered, again, asked as examination direct question. Right? So it has been found that see, everybody knows that second trimester is the safest for any treatment, right? So between week 13 and 21 weeks is your safest period. And emergency treatment, we have been doing that it can be done anytime with precautions. Your generic gold standard LA, which is your lignocaine with adrenaline, again, it is completely safe to use. There is no contraindication to use lignocaine and adrenaline unless there is a medical condition which requires you to control the amount and dose of the adrenaline, like in preeclampsia patients or in hypertensive pregnant women. Of course, you're going to avoid or at least limit the volume and the amount of your adrenaline that you inject. Other than that, there is no contraindication to the gold standard LA. Now, with the newer guidelines, we will talk about it, that if there is any source of infection present, and if it may not be an immediate emergency, because emergency in dentistry is what? Severe pain, right? Immediate irreversible pulpitis, usually that is an emergency. Severe pain is an emergency. Even if it's not irreversible, symptomatic, extremely painful emergency situation. But if there is an existing source of infection, even if that is a localized periodontal abscess, and if it requires extraction, even without being an emergency management, you can and you must remove the source of infection, and you can do that procedure anytime during pregnancy. Is that crystal clear for everybody? Right? Now, a lot of pregnant women can come to you and they might ask you for replacement of amalgam restorations, right? That also happens. In pregnancy, they start going and, start searching a lot of stuff. So one very common thing and a pattern that emerges is pregnant women coming and asking for removal of amalgam restoration. Again, a very classic examination situation. How are you going to handle it? Well, you're going to tell the patient that they are not required, should educate them in your best capacity that it should be avoided, right? Because release of the mercury vapor would be more harmful for the pregnant woman and the unborn child, right? So especially in the first trimester when it's the organogenesis going on, you will completely avoid amalgam removal because you don't want to expose the foreign substances in the patient's body systemically, because in the first trimester only majority organogenesis happen, right? Now for the radiography in pregnancy, again, if you can use the collimation, the lead apron, it's entirely safe throughout the pregnancy if the diagnosis of a condition indicates an x-ray following the ALARA rule, LRA rule, as low as reasonably applicable. Till you're applying that rule, there is entirely no risk and it's completely safe throughout the pregnancy, but it should be indicated for the diagnosis of the patient's chief complaint, right? Now, what can be the problem in the newborn babies after the birth, what can be the issues that you may see in the newborn babies, which also sometimes get asked in the exam. With the newborn baby, you can have some natal teeth and cysts. They are like the Epstein pearls, right? And they can be seen on the maxillary gum pads. So all these are rare occurrence, but sometimes may be found in an unborn child. Oh, sorry, in the newborn child, right? Now, also you must educate the patient about transmission of Streptococcus mutans, especially if your patient was classified as high caries risk in their pregnancy, then you know that they have high S mutans count. And by kissing and the newborn when it's born through the vaginal canal as well as through kissing and direct contact with the saliva, there is a high risk that they can expose the child with those high S mutants to the newborn as well. So educate the patient on reducing the transmission, right? And before birth only give them the restorative management, preventive management, so their S counts already declines. Giving them the mouthwashes, reducing their sugary diet, good oral hygiene, fluoride exposure, everything, and giving restorations on existing caries. All this will make sure that the risk and the amount of S mutans is going low. Is that right or wrong? Yes. So there is a risk. Definitely, a mom is going to give kiss their newborn and everything. So there is going to be the transmission. So to prevent that, already work on reducing the S mutants load. Now there are certain problems that as the child grows and the new mom would bring the child for certain problems like use of pacifiers and finger sucking. Now that's also one of the challenges that you might see in the first year or the second year of the child's birth. So then there is a certain risk criteria that you must educate your patient when they come with the concern of the sucking habit. Now the sucking habit with the pacifier is easier to break than your finger sucking or thumb sucking. Clear for everyone. It's an examination question. Rash will need you to know this to rule out. So rash will only work when you're feeding it with the concepts, and that is why with every session I try to give you as much information, as much concepts that you can effectively use rash. So finger sucking and thumb sucking are harder to break habits, and pacifier sucking is an easier to break habit, right? And there are certain effects of the sucking habits. Now, usually if it is done only till the first year, till the 12 months, there is no detrimental effect on the oral health. One thing you will educate to your patient. Yes or no, please. Strong concept directly applied to the exam. Till the first year, there will be no detrimental effect on the dentition. Up till the use, if use goes up till 36 months, which is 3 years, right? Then there is a risk of developing occlusal effects, right? Like anterior open bite. Only 3 years or beyond, it will develop into occlusal discrepancies, detrimental effects on anterior open bite and a class 2 canine relationship. Agreed? So 36 months or more, 3 years or more, if they're doing the digit sucking, thumb sucking, or your pacifier use, then the anterior open bite risk increases, right? Now, the posterior crossbite and constriction of the maxilla, which is the worst outcome, and you have done those concepts with me in the thousands in the past paper classes as well. So the posterior constriction of the maxillary arches and development of posterior crossbite, which is extremely harmful for the developing face, will only be seen when there is, again, 3 years or more use, 36 months or use more than that. Again, so anterior open bite with constricted posterior maxilla requires 3 years or more use. And then the excessive overjet would be for 60 months, right? So 5 years plus will give you excessive overjet. Clear for everyone? So up till 12 months, no risk. 3 years or more, you will get anterior open bite, class 2 canine relationship, and a posterior constricted maxilla and crossbite. 5 years plus, you will get an increased overjet as well. Crystal clear for everybody? These are extremely crucial exam concepts. Without knowing these by heart, the rash will not work. You will never be able to tell the right option between the wrong. Agreed? So just to reiterate, what are the common oral health conditions during pregnancy? Right? There is pregnancy gingivitis, yes or no? Hormonal changes leading to inflammatory response in plaque, causing gingiva to swell and bleed more easily, right? Most commonly seen during the second trimester, gradually reduces after childbirth. The other outcome is periodontitis. Gingivitis can progress to periodontitis if not being managed. And periodontitis during pregnancy is a potential risk for adverse pregnancy outcomes, preeclampsia, preterm birth, low birth weight. Then perimylolysis, which is another name for dental erosion, due to gastric acid from vomiting and hyperemesis, morning sickness. So it can lead to the loss of tooth structure, enamel erosion, caries risk, xerostomia risk, because excessive vomiting can also give you sensation of dry mouth. That's what xerostomia is, right? Perceived dry mouth. Then dental caries risk, because of increased levels of S mutans, because of excessive hormones in the gingiva. Again, the bacteria flourishes in that environment. It thrives in that environment. And there is increased sugary drink consumption. So dental caries is also potentially increased risk. Pyogenic granuloma, 5% of women can have that. Excessive and large swelling on the gingiva, localized, highly vascular, and because of increased progesterone. And there should be local irritations, local irritants and bacteria and plaque, which can trigger the pyogenic granuloma. Usually most common after the first trimester, grows rapidly, and usually automatically subsides after delivery. Crystal clear all the conditions that you will find and the risk of all these oral conditions on the general health: preterm birth, low birth weight, and preeclampsia. Now there are certain guidelines and interventions and advices that you must give to your patients, right? So most important thing is, the most important advice is that they must keep visiting the dentist regularly during their pregnancy and even before they're trying to conceive, right? So ideally, before they're trying to conceive, their medical practitioners should refer them to you. Is that right or wrong? Because avoiding periodontitis and treating it before you conceive would be the best way to have the safest and the healthiest pregnancy. Brushing twice daily, using soft toothbrush, fluoridated toothpaste, reducing the caries risk, reducing the periodontal disease, everything will give them the optimum health. Now, patients who are pregnant and develop vomiting, there are certain advices which goes for them. Again, brushing should not happen for at least 30 minutes. That is clear for everybody. And after 30 minutes, it should happen with a fluoridated toothpaste. And then immediately after vomiting, it has to be rinsing with water or rinsing with sodium bicarbonate or rinsing with fluoridated mouthwash. Now, when you compare all three, the sequencing would be the best. Again, becomes your fluoride, right? Then it becomes your sodium bicarbonate because it is pH is basic. It neutralizes the acid. And then last one would be water in sequencing, in most beneficial for the teeth. Understood? Clear for everyone. All three are recommended in guidelines. Sequentially, you will choose fluoride, then sodium bicarbonate, and then water. Right? Considering the effect that it brings on the oral plaque and the teeth. They can also chew some sugar-free gums to stimulate saliva and clear and neutralize the acids, right? But the most important is rinsing the mouth immediately after exposure and 30 minutes wait for brushing. So there should be regular referral protocol by the medical practitioners to the dental practitioners for. Yes, Sarah, we are going to talk about that on Thursday class. Yes, hold that thought there. Okay, right. So that is already covered. That's on my mind. Absolutely. Now, the medical practitioners should take care when they identify any of these problems to send these pregnant women for regular dental checkup. And as a dentist, it's your responsibility that you identify these issues, and the advices and education and management is clear for everyone for all the dental situations that you will find in pregnant women. Yes or no, please? Clear? Crystal clear? Wonderful. Now, the other important absolute management that you would do for pregnant women is, number one concern is when there is active dental infection. We've talked about the chronic conditions, right? The caries, the gingivitis, the periodontitis, pyogenic granuloma, erosion, they will happen over time. Now, there can be certain acute conditions also, right? Infections also present. Is that right? So now the biggest questions that come in the pregnant woman's mind is it safe to get the treatment during that time? So as I said, the LA and the X-rays are absolutely safe. Giving dental treatment during pregnancy is throughout the pregnancy safe. If it is if the source of infection is present, then any time during the pregnancy you should remove the source of infection. And can mothers pass bacteria to their baby? Yes, absolutely. There is an increased risk of early childhood caries if the mother had high caries risk. Is calcium important in their diet? Yes, absolutely. Consuming diet which is rich in calcium will improve the dental health and the bone health of the developing child. Yes, is that clear for everyone? If these questions are asked by a pregnant woman, so these four questions will help you answer the professionalism and health promotion questions, which are again being asked in the exam. So again, we know that when and why would you need to do immediate dental treatments during pregnancy, right? So checkups are safe to do, LAs are safe to do, X-rays are safe, procedures which are safe are fillings, root canals and extractions. All three remove the source of infection, even scaling and local debridement for a localized periodontal abscess or periodontitis is removal of source of infection only, right? When you do the scaling and localized debridement, you are removing the source of infection. Even when you're doing subgingival scaling, you're removing the calculus. Even if you're doing your root planing, you would be doing it in the severe deep pockets, right? That means they're severely deep infected pockets. So fillings, root canals, extractions, including periodontal disease management using periodontal treatments, whether it's scaling, subgingival scaling, or even if surgery is required, that of course would be in your severe cases, right? So should be indicated. Because if the periodontal disease is too severe, then the adverse effects on pregnancy are also going to be too severe. That's why before they're trying to conceive, they must visit a dentist, and severe periodontitis should be treated before conceiving. RCTs are also absolutely safe. Extractions also, Kuljit, absolutely safe. Even most antibiotics are safe to use, which are commonly used for the management of dental conditions. So all these issues for pregnancy, the checkups, the LAs, the X-rays, the procedures and infections, management using antibiotics, all these 5 checkpoints are clear for everyone? How safe they are? Clear for everybody, right? Because these concepts will help you choose options in exam. Again, they're rash feeders, direct. Now there is requirement of pain management, right? So you can use paracetamol and opioid, of course, not codeine directly because that's not advised. So you use oxycodone for the pain management, right? RCTs are done in a very long appointment, Kojit. Is RCT a very long appointment? You can avoid doing it in single visit, right? And you can have multiple visits. So pain management is done with using paracetamol and oxycodone, but not NSAID. From 2020, and it's also in your latest TG, NSAIDs completely should be avoided now throughout the pregnancy. used with caution is that it's not an absolute contraindication and it will only be used for severe pain management, Sakshi, not for your mild to moderate pains. And usually in dental situations, you have mild to moderate pain, so your best answers are paracetamols, right? In extreme severe cases, you can give oxycodone. There is no direct adverse effect of oxycodone on unborn child. But ibuprofen, diclofenac, NSAIDs, they have harmful effect and they are no longer recommended to be used in pregnancy. Does that make sense to everyone? I want this to be one of the topmost takeaway points from today's lecture. NSAIDs are no longer recommended in pregnancy. 2019 TG that you're doing will advise you something else. Please ignore that. The latest TG, and I do have a screenshot from the latest TG also, so I will post it on our study buddy group as well. Oxycodone alone, no, Nivedita. It has to come with the paracetamol so that the majority management also, so that the lowest dose can be kept for oxycodone. Right, Nivedita? So the lowest possible dose can be used. It will be with the paracetamol, and that too on very severe conditions where and usually for your dental situations, active dental treatment mostly removes the source of infection and manages the pain. And absolutely avoid NSAIDs at different stages of pregnancy, right? Yes, yes, Ruba. Now, how can they do their oral mouth care? So there are certain mouthwashes, there are certain antiseptics. Now the use of chlorhexidine, cetylpyridinium, and alcohol-containing mouthwashes. Is it safe to advise for your pregnant patients? Give me what's your opinion about it. Yes, during breastfeeding, Aldo, absolutely safe to give ibuprofen. Well done, good question. I was about to cover that. I am going to cover that, but your concept is right. So now tell me, chlorhexidine, cetylpyridinium, or alcohol-containing mouthwashes, are they safe to use? Yes. But educate them that they should always be spat out. Shravani, forget about what is given in the 2019 TG. I'm going to send you the latest TG stance on the use of NSAID. I'll send you the screenshot on the group. Okay? Now, forget about the 2019 progeny. Is everyone registering? What's on the 2019? Forget about it. It's obsolete concept. I'm going to share the latest stance of TG also there. And that's what you will follow. Coming back to the mouthwashes, there is no contraindication. There is minimal absorption. So you can tell them that they can use, but they should never swallow. Okay? So there is no increased pregnancy risk with that. Now coming to breastfeeding situations. In breastfeeding situations, most antibiotics are safe to use, right? Again, and even NSAIDs. For pain relief in breastfeeding, it would be paracetamol and NSAID. And both ibuprofen and diclofenac are considered compatible with breastfeeding. Is that clear for everyone? So the dental checkups, x-rays and LAs were safe in pregnancy and in breastfeeding both. NSAIDs not in pregnancy, but when after birth, during breastfeeding, NSAIDs again become compatible. Clear for everyone? Now the use of opioids in breastfeeding actually should be avoided, right? So usually the use of opioids in breastfeeding should be avoided, but if it is again severe pain and is required, then it should be dosed and consumed in a way that it should be done after feeding the baby. Because if it's in your bloodstream during breastfeeding, then it can cause drowsiness in the child, right? So that is absolutely any source of infection. Antibiotics are safe to use, right? And if you're not treating a dental infection in pregnancy, then there's an increased risk of poor pregnancy outcomes. But giving active dental treatment is actually preventive of multiple adverse outcomes. So antibiotics may be required sometimes in pregnancy to treat dental infections. In which situations, Gabby, you would require? When it's spreading infection, right? Or severe condition. Spreading and severe situations will demand the antibiotics. And what are your advised antibiotics? So it's penicillin group, right? Right? Or metronidazole, right? So both are safe to be used during pregnancy. That is why the common antibiotics which are required to treat dental infections are safe to be used during pregnancy, and that is why not treating the infection and postponing it would be a greater risk for the poorer pregnancy outcomes. Now, what are the situations where you may give tetracycline? Very, very rare. Very, very rare. There is one indication, right? Avulsion only, right? And that is also not an absolute requirement, is it? It's not an absolute requirement, right? So that is why try to avoid it, because again, tetracycline single dose will not cause the staining, first of all. It is usually longer tetracycline exposure which will lead to those, right, stains. And permanent teeth are not yet forming in the gestational period, are they? So even if there is a risk, it will not affect the permanent dentition. So if it is indicated for periodontitis management, yes, so replace it with doxy, which is not associated with staining. Periodontitis condition and treatment of severe periodontitis may demand the use of tetracycline family. Is that right? Because doxy and tetracycline also have effect, right? Then you would use aspirin, Sarah, right? Aspirin is another drug indicated for the emergency management of angina. And then their medical practitioner would have advised them their emergency drugs during pregnancy if a pregnant woman already has an existing angina, uncontrolled angina. Clear for everyone? So far, all the concepts related to all these. So doxy can be demanded or can be required in periodontitis management, right? And then you should, there's a low risk of staining, and plus it would not affect the permanent dentition anyways. So coming back to your nausea, vomiting, do's and don'ts that you must educate your patient is: rinse with water or fluoride mouthwash, smear the fluoride toothpaste, but when you're smearing the fluoride toothpaste, it has to be done after rinsing. Is that clear for everyone? Rinse with water and then smear a small amount of fluoride toothpaste on teeth. Clear for everybody? Again, very crucial to rule out your correct and incorrect. And this is what was recently asked in exam also. All the concepts that I'm teaching you are your recent exam concepts. Then take snacks which are cheese and milk based. So they are more, neutralizing. They are more calcium providing. So again, healthier, karyostatic, help with counteracting the erosive effects. And eat plain foods like toasts and crackers, which will settle their nausea, settle their acidity, right? So these are the certain do's that you must advise them. Then avoid sugary or acidic snacks and drinks. Don't brush immediately after vomiting, and avoid snacking on foods with sugar, right? So now the advices that you will be giving them is brushing their teeth twice a day, soft toothbrush, fluoridated toothpaste, floss daily, right? And if there are bleeding gums and gingivitis, go for your regular dental checkups and eliminate the disease. And smoking, crucial to educate pregnant women, especially those who smoke, to help them quit, and telling them what are the effects. After smearing, 30 minutes after, you brush it, Gabby. So you rinse before smearing, right? And you keep it in the on the mouth and smear it, keep it there so that the fluoride gets uptaken. And then 30 minutes later, you're going to brush anyways, right? So all the dental appointments should be met, regular appointments and checkups should be performed. Now let's come to the most important takeaway guideline from this lecture, which would be the management of smoking and pregnancy. So you have to first educate the child about what is the harm of smoking to the pregnant woman, that we know, right? In the adult other smoking guidelines, we have learned all the harmful effects, immediate effects, long-term effects, over the months, over the years, everything. Even withdrawal effects, the after quitting, what are the effects? Everything you've done in the smoking quitting guidelines with me. So those you will use to educate the effects on the mother's health. But what about the unborn baby? So the umbilical cord that connects, the mother and the child carries the oxygen and nutrients to the baby. And with your smoking, when they inhale all the carbon monoxide, it reduces the amount of oxygen going through the umbilical cord to the baby. It makes the baby's heart rate go rapid. It increases the stress on baby's developing body, and it also reduces the flow of blood to the body. So nutritional deficiencies start within the body, within the gestational period. Does that make sense for everybody? So reduces the oxygen, reduces the blood flow, increases the unborn baby's heart rate, and puts stress on the baby's developing body. So it causes harm during pregnancy and birth. It can lead to ectopic pregnancy. Smokers who are planning to conceive, who are trying to conceive, are at a higher risk of ectopic pregnancies. That means pregnancies outside the uterus, usually in the tubes. And then that leads to miscarriages, injuries, right? Severe injuries. They're also at increased risk of having a premature baby, just like your severe periodontitis. Having again low birth weight, same risk as periodontitis, right? And even the birth is difficult. So there's not just low birth weight, and there's not just body getting affected while developing, or premature birth, or ectopic pregnancies. Even during the birth, the baby is so weak that sometimes cannot withstand the birth process, because birthing again is stressful for the baby also, right? Especially through the vaginal canal, the natural birthing is stressful for the baby. It puts stress on the baby. And in smokers, the babies are underdeveloped because of the persistent oxygen deficiencies and nutritional deficiencies. Sometimes the baby cannot survive the birthing. Clear for everyone? These are the education and the health promotional points that you must know and educate your patients on. Right? Clear for everybody? So, and educate them that if they quit the smoking within the first 16 weeks of pregnancy, they can have all the harmful effects avoided. Yes, absolutely, Nivedita. I'm going to add it on the hot notes also, this article, and I'm going to upload it on the latest article folder as well. Okay? So there is a risk that and the most important education point, now this will be a direct exam question and Rash will be directly needing this concept, is if they quit smoking within the first 16 weeks, the answer is 16 weeks, most of the harmfuls can be avoided. There is a sudden infant death syndrome risk also, which is extremely high in smokers. So SIDS, which is sudden infant death syndrome, or cot death, is also higher in if there have been smoking throughout the pregnancy, right? They are also more likely to suffer with asthma, respiratory infections, and middle ear infections. Clear for everyone? After birth also the effects persist. So even if the baby sustains and survives the birthing process, gets into the optimum weight, is not prematurely born, even if those are bypassed and avoided, then also they are more prone to have asthma, respiratory infections, and middle ear infections. Then if they continue to smoke, in the breastfeeding also, the smoke enters the bloodstream. All the harmful chemicals, 7,000 chemicals in single smoke, they all enter the bloodstream of the mother, goes to the breast milk, enters the baby's body. All the harmful substances enter. So how will you educate them if they are smoking during the breastfeeding? Is don't smoke just before or during the feed. Because just before or during the feeds, make sure that your vascularity, your circulation carries those without getting eliminated yet. And all the breast milk, it's formed with your existing circulation at that point. Then don't smoke in the room that your child uses, baby uses. Go smoke outside. Wear and cover your hair and your body so that when you come back, you don't have the smoke on your hair, on your body. Wash your face and hands before handling the baby. Do not expose them. Clear for everyone? The guidelines during the breastfeeding also, absolute advices for the patient. Now, the passive smoking, if the mother is not smoking, but someone else in the family, or you take the child to places where there are smokers, they also affect the health of the babies. So, do not expose your babies to adults who are smoking around them because they have delicate lungs still developing, right? They are more affected by tobacco smoke, right? So keep your baby safe by advising the people who are smokers in your family to go outside your home and then smoke there in their cars or outside your home, but not in your home. So if even if your mother is not, the mother is not smoking, even other family members or visitors or guests should not smoke around the baby. Now comes the most important point. How to make them quit. What are the advices? Again, quit line, educating them, providing them support. Everything is same like we are doing for non-pregnant patients also. That goes without saying. So you will tell them that quit line number is this, speak to the trained advisor, and encourage them to quit. Now, what are the indications for NRT? What form it is advised in, what is the dose that is usually used for non-pregnant patients, and what is the dose that you will use for pregnant patients, because still there is nicotine in there, right? And nicotine also still has effect on the circulation, right? But it is still better than smoking because it eliminates the other 7,000 poisons which are present in cigarettes. Is that clear for everyone? So best method to quit is without NRT in pregnant patients. Best advice would be to quit without NRT. Crystal clear for everyone. Number one advice. Still, if you cannot, you can choose NRT because it's safer than still continuing to smoke, and you will have less nicotine than cigarettes. And again, another 7,000 poisons also will be completely removed. Now, the patches are not advised for pregnant patients routinely. Most advised method should be in the oral form. Gum, lozenges, strips, sprays, or inhalators. Why? Because the oral forms give you occasional dose, whereas a patch gives you a persistent, sustained dose. Clear for everyone? So for non-pregnant patients, patches are preferred. And in pregnant patients, oral NRT is preferred. Now that's exactly exam question or not? And can you answer these without knowing the guidelines? These are your rash feeders. You cannot rule out. You will never know which is multiple correct answers. How will you choose what answer my questions, or how will you sequence it, how the history affects it, unless you know what's right from wrong? So oral is preferred because that is an occasional dose rather than a constant dose which comes from a patch. And pregnant women require higher dose than your non-pregnant patients. So in non-pregnant patients, you require 2 milligram of oral dose, whereas in pregnant patient, you require 4 milligram of nicotine dose. Any reason why? Can anyone say why? Because there is hypermolarity during pregnancy, the metabolism is higher and quicker, so you require double the dose due to faster metabolism. If they cannot withstand oral forms, then only you can advise them the patches, right? And it is important that they don't continue to wear the patch throughout the day. So take it off in the night and apply a new patch in the morning, right? So that should be the combination therapy, right? So these are the advices. Now, NRT use while breastfeeding. What is the guideline for NRT use while breastfeeding is? Again, use it after breastfeeding. Well, it can be used for multiple weeks, Kirti, till the quitting happens, because quitting is extremely important during pregnancy because of the before said reasons, right? The harmful effects are far too severe, right? Than the nicotine effects. Now, if a pregnant woman says that you're saying, okay, 16 weeks is the best period to quit, but I'm already 3 months pregnant. Now, is it really important and worth quitting? So then, yes, quitting within the first 16 weeks may have the best effect. It will immediately reduce the risk of having a low birth baby or, premature birth, right? But even if you're beyond 16 weeks, then also quitting any time is still good for them and the baby. So oral dose at a single time is given 2 milligrams in the non-pregnant patients, Kaylee, right? But for oral dose in pregnant patients would be 4 milligram per oral lozenge or tablet. Got it? Everybody double the dose in pregnant patient because the metabolism is quicker and faster. Absorbed dose would be same as 2 mg only. Okay. And maximum 24-hour dose could go throughout the day up to, 20 milligrams, depending upon what is the need of the patient. Yes, Kirti. Yes. Well, again, Sneha, we have done the combination therapy also. We have discussed those smoking guidelines, smoking cessation guidelines, right? So combination works better than your single approach in non-pregnant. But in pregnant patients, again, they are drugs, they are systemic drugs. So the medical practitioner will take that final call, how severe and how much of the smoking is being done. Because patches give you persistent continuous nicotine in bloodstream, Neha. Oral dose gives you smaller dose and then for hours the blood will not have nicotine. Okay, so occasional exposure is better than a persistent continuous nicotine because again nicotine still constricts the vasculature, right? So again umbilical cord and vasculature to the fetus will still get affected. It's like hypertensive, right? Adrenergic effect is still there. So you don't want a consistent, persistent adrenergic effect. All right. So these are your most important smoking quitting guidelines for your pregnant patients. Not patches at all. No, Mitali. I showed you, no? We talked about it. If they cannot tolerate oral NRT, then patches may be used. But they have to take it, remove it at bedtime. So that 24-hour nicotine is not in the stream. Got this? Right? So Mitali, all these concepts I will be adding and feeding into the hot notes. The newer guidelines will be uploaded also. You won't require to read the newer guidelines because it would be added under the hot notes now. All right, let's do the SVQ now. So periodontal screening reading given to a pregnant patient who's 10 weeks pregnant during the basic periodontal examination. She says that she is drinking a lot of sugary drinks. She tries to quit, but she could not quit at this point of time. There was inflammation of marginal gingiva and rolled margins. They mentioned the diagnosis as mild to moderate marginal gingival inflammation with bleeding on probing present, and the BPE scores were this 212 and 121 in all the 6 sextants. So if your scores are within 1 or 2, less than 3, let's answer this question now. So during the perio week, you have done with me the complete BPE examination, meaning of each score. what each score means, how would you define score 0, score 1, score 2, 3, 4, and the asterisks with the furcation involvement. Absolutely crystal clear and memorized by everyone. Then comes your management and the treatment that is required after getting and seeing a score. So if it is less than 3, do you require any perio assessment? No, we don't. Then based on the patient's reading, do we do complete periodontal assessment and charting? No, right? So C, D, and E get ruled out. Between A and B, you would not do the perio assessment, but the score is also 2. If the score was everywhere 1, then you will just give oral hygiene instructions. Is that right? But if your score is 2 as well, then you will also do local debridement scaling because there are local factors present in score number 2. Is that right? Now, how will you protect her teeth from sugary drinks? So, would you advise her to drink cola with straw during meal, gargle with the water after meal, brush 1 hour after with fluoridated toothpaste? Everything seems right, but the only missing word here is sugar-free cola. Is that right? Unless you're making it sugar-free, there is still the excessive sugar exposure, which will be leading to higher erosion and higher caries risk. So D gets ruled out. Would you advise her to drink sugar-free cola with straw during meals and gargle with water and brush 1 hour after with fluoridated toothpaste? Yes. Let's keep it. It's a correct approach. Ask her to drink with the straw and immediately brush with fluoride. Again, ask her to drink with straw. She's taking sugary drinks. Again, doesn't advise for sugar-free. So B gets ruled out. And immediately brush. Absolutely incorrect. Immediately ruled out. Now, ask her to drink the sugar-free drink with the straw, correct approach. Immediately gargle with the water, correct approach. And use fluoridated toothpaste 5000, also correct approach. So A and C are both correct. Now, which is better? Does A limit it to the meals? No. Does A talk about frequency? No. Between A versus C, A does not limit the frequency, limited with the meals. So during meals is one of the best advice that you can give for frequent snacking and erosive exposures. Both have fluoride. Yes, 5000 is stronger than 1450, but 1450 is also with multiple use is good and protective and preventive. But taking the sugar-free drinks, where they are still acidic, right? Even if they're sugar-free, they're still acidic. The pH would be still low. So when you move them to the meals, you're making sure that the erosive exposures are also reduced. And frequency is one of the most crucial factor for the detrimental effect of the repeated demineralization cycles happening is far more detrimental to the patient. She's no, it's mentioned that she's taking sugary drinks, a lot of sugary drinks every day. So they have mentioned she's doing a lot of sugary drinks, Nivedita. It's given in the history, right? She's not saying she's having it once a day. Yeah, that also, if not mentioned, still putting your exposure. The elimination of etiological agents is far more powerful or just fluoride alone, Nivedita. That is how you're comparing here. You're sequencing it here. In sequentially, which is more important and protective? Reducing the etiological factors. Number one benefit. She is definitely a high caries risk patient, right, Daniela, when she's consuming sugary drinks a lot of time, right? So turning it to a non-sugary or sugar-free drink. Number one, Daniela, you have done the CV class or a special topic class where I also talked about the sugar control and management diet assessment lecture. Remember? Anyone? We have done the sugary drink management in that also. So it was not just about making it sugar-free. It was also about reducing the frequency. Everyone remembers that? Where we talked about the Teresa article. We have done all those guidelines, right? So you're going to advise her to drink it with the straw, gargle with the water, and only consume it during meals. So ultimately, you're anyways minim because in A option, if you're is and she's used to taking it lot of times. If your option A is not including the advice on reducing the lot of times to just 2 meals, then it's an incomplete advice. Does that make sense now better, Nivedita? Because that's a chief complaint and that's a chief problem, a bad habit to break. And option A does not talk about breaking that habit of reducing the frequency. Yes. So answer will become C. If both the options were given, reducing the frequency and then 5,000 will be a good option. But with incomplete management of already what's going wrong, a lot of drink consumption. So if you don't advise her to only move it to the meals, then every day if she keeps drinking in between the meals also, that's a repeated remineralization or demineralization that your tooth is facing. So 1450 will also protect the demineralized enamel. That also is a good strength of fluoride to have preventive effects. But repeated demineralization, even 5,000 will struggle because of the repeated exposure to the etiological factor, Nikita. Does that make sense now? Yes. Now, clinical signs of gingivitis will be, so it's a general question. If asked for this patient, she had rolled marginal inflammation, but it's a general question. What is the most important clinical sign of gingivitis? Well, the first where it starts. I've taught you in the perio basic classes, the 1000 and past papers periodontology classes. And it is, yes, absolutely the Facebook question. It is the interdental papilla, the coal region. Absolutely. So you guys are paying attention to every zone, every area. I really like that. So yes, it starts with the interdental papilla, not the marginal, not the attached gingiva, and not the calculus always. Calculus is one of the possible etiological agents, but the most important one is the plaque. So answer is A, inflammation of interdental papilla is the most important and the first clinical sign of gingivitis. Now she asks about the future child and how to clean the child's tooth. So unless there is excessively high caries risk, in the normal caries situation, normal risk situation, you start the fluoridated toothpaste in the newborns at the age of 18 months. And that strength has to be 500 to 550 ppm. So not at 24 months, absolutely wrong, and not with the 1000. So B gets ruled out. And yes, the strength of 500 to 550 is correct, but the 6-month interval, 6 months age is incorrect. So answer becomes A, at the age of 18 months, right? 500 to 550 ppm toothpaste, fluoridated toothpaste. And if the dentist were to do a health promotion event, what is the best advice you can give to a pregnant patient? So if you were doing a health promotion event and there were pregnant women there, what is the best advice you can give? Pregnancy will cause dental caries. First of all, pregnancy, due to the changes in the dietary habits, increases the risk of caries. Cannot by definite way say it will cause dental caries. So it's an incorrect question. Get the treatment for periodontal disease versus meet your dentist to avoid periodontal disease. Prevention is better than cure. Preventive advices are superior than your curative. Of course, C would be a part of your advice, but the most important advice first would be to avoid getting severity or increased periodontal disease. Pregnancy always causes gingivitis? Absolutely not. With meticulous oral hygiene practices, eliminating plaque, using fluoride, changing your diet, completely can avoid periodontal disease, caries, pyogenic granulomas. They don't happen in every pregnant patient, but where it happens, have very severe adverse effects. That's why should be best avoided. So B is the best answer amongst the given. And these are your actual exam questions. But today you have prepared far more difficult concepts that you needed to answer these questions. But you have now in today's session learned more advanced concepts, more advanced advices, especially the smoking and periodont. Kirti, go ahead. Please put your question there. So I'm sure you're feeling far more strengthened, powerful, empowered entirely to handle any pregnancy related question, whether it's about doing extraction, taking x-rays, giving LA, antibiotics, painkillers, whether it's about all the oral manifestations, whether about all the general health effects, the baby's effect, the neonatal effects, the smoking effects, everything. If you close your eyes about pregnancy, oral health, smoking, multiple oral dental infections, drugs use, x-ray use, LA use, everything is covered. Absolutely, completely avoided. Teratogenic effects, especially in the first month, birth defects, absolute link with birth defects, alcohol, absolute prohibited, right? First and foremost, beneficial is fluoride rinse, then bicarbonate, and then last is water mega. Okay? Sequentially. So I'm sure you all feel empowered, and thank you so much for being the fabulous audience that you always are. I hope you enjoyed learning today, and it was a very strong concept, very strong lecture, helps you with at least 2 to 3 SBQs during exam. So yeah, thank you so much. Thank you so much. And I'll see you on Thursday. We are going to review some questions, do further 5 pages. We are following it. There's a change, Raman. I'm going to share the NSAID newer stance of the updated TG concept. Okay? Thank you. And you were amazing. The reception, I could palpate it. There were very, calculated questions. There was no bombardment. You again. And I'm noticing more and more the weeks are going by. Now you're getting in the receptive mode. And also there's one reason behind it now. So you've done the first 12 weeks of the program. So yeah, now you're fully, empowered with the knowledge, and when you receive the lectures now, so you can process them, you already have the founding stones, you have the foundation. Yes, you may give it, but with smoking you're giving another 7,000 poisons, remember, Prajani? So this is a much smaller evil. And a child, even if it gets dependence, a newborn will not ask for a smoke, right? So slowly that will also get rid of the child's body, right? So ulceration is a withdrawal effect, cessation effect of smoking. So how will it give ulcer in a kid's mouth? If mother quits smoking, Shravani, how will it give ulcer in a kid, right? It would give ulcer in the mother's mouth, right? Not in the baby's mouth. Feeding and amalgam removal, yes, again, number one point, you have to advise that it is not required. You have to educate the patient about all the adverse effects, amalgam, mercury vapor generation. But if still the mother insists, then as per the latest amalgam removal guidelines, you will do that. But high evacuation, high volume evacuation, rubber dam, and remove it. Of course, Kirti, right? We have the guidelines about those as well. So that's sorted. Yes, absolutely. Full periodontal charting, any score above 3. Okay? Thank you. Yes, Sakshi, we are going to review it on the Thursday class. We'll make the changes on the file as well. See, the radiation guidelines do not recommend Prajani, but then the pregnancy guidelines that they keep releasing for the safety, they have mentioned that you use it. So using a lead apron is not a big thing, right? If you use it, it just helps psychologically. But as per the radiation scientific guidelines, unless you're taking a true maxillary occlusal view, there is no direct primary beam projected towards the fetus, so there's no greater risk. Okay, but using a lead apron actually would help with the also with the absorption of secondary radiation, environmental radiation, right? Thank you so much, guys. Thank you for being the fabulous audience that you always are. And I'll see you on Thursday for our internal session, Ultimate Advanced File Volume 2. And we'll do the next 5 pages thereafter. Okay. So thank you so much. Bye bye. Have a good day. Thank you, Saida. Thank you, Kulji. Thank you, Garima. Everybody. Thank you so much. Thank you, Kiza. I'll see you on Thursday.